Right. I think we don't have too many people here, but I think we're gonna get started just because we want to honor those people who arrived on time. And we also know that it's a holiday week, and so we have a smaller audience today, which is fine. And if people who are here could sort of feel free to remind their friends and colleagues that this is going to be available online, so people might want to listen to it asynchronously if they didn't get to attend in person. But anyhow, I'm Barry Sarvet. I'm the statewide medical director for MCPAP. I'm a child psychiatrist from UMass Chan Medical School, Bay State, and we're really pleased to have our session, our clinical conversation session today. Um, we, as usual, meet on the fourth Tuesday of the month. We are not meeting in December just because it falls, right during the holiday week, and so our next session will be January 28th, and we'll provide more information about that when we get a little bit closer. Just a little bit of housekeeping. That, as usual, we have CME available for anybody who needs it and wants it. And the code is on the screen in front of you, but if you're on the phone, the code is SELWOG. We record the session, so you can listen to it streaming on the MCPAP website. The slides are available. They will be available on the MCPAP website under the Toolkits and Resources tab. And our presenter will be happy to field questions, which can be entered into the chat. So feel free to enter whatever questions you have in there, and we'll either take them during the presentation or at the end, depending upon what the question is. And please, if you have a moment to fill out a survey at the end, which you'll see, it's really, really important to us, and we really appreciate it. For today, our topic is addressing the unique needs of patients living with chronic illness. So really special healthcare needs with kids, and particularly around the mental health, aspects of that. Our speaker is, we're very proud to have Dr. Joshua Brown, who is a triple boarder, as they say, which is being a child psychiatrist, an adult psychiatrist, and a pediatrician. So he did his training at Tufts, which is one of the excellent triple board programs in the country. And he specializes in working with kids and young adults with medical trauma. And he also works as an attending child and adolescent psychiatrist at Mass General, where he runs the outpatient CHAMP program, which stands for the Child and Adolescent Medical Psychiatry Clinic. And we're proud to have Josh, Dr. Brown, as one of our child psychiatrists in MCPAP. He's also an attending at Dana-Farber and an instructor of psychiatry at Harvard Medical School. So please join me in welcoming Dr. Brown, and I'm going to just hand off to him to get started.
Thank you so much, Barry. Really appreciate the introduction. I think if we could pull up the slides. Okay, excellent. Thank you. All right, so there we go, even bigger. All right, so yeah, so today's topic is going to be addressing the unique psychiatric needs of patients living with chronic illness. And our objectives today is, first of all, just define what we mean by having medical trauma, and actually differentiate medical trauma from what's classically known as PTSD, because there are some notable differences between those two topics. We're going to talk about how to think about medical trauma through like the biopsychosocial, and I always add spiritual framework. And then also we're going to spend some time going through different treatment modalities that we can use to help our patients cope with their chronic illness. So next slide, please. So I'm just going to introduce the topic by giving 3 separate just cases, very brief summaries of cases just to show a little bit of a spectrum of the types of different kinds of chronic illnesses that I'm sure many of you encounter. So let's say case number one would be, these are all patients of mine, a 14-year-old with a recurrent optic glioma, resulted in blindness in the left eye and a seizure disorder. Was treated on past chemo trials, had resection of the tumor, now takes oral daily chemo, and had labs and scans every 3 months. And this is, by the way, true for many, many patients. They're constantly waiting to, anticipating that next blood work that they're going to get, those next scans. In this particular case, there was lots of family discord. Patient had learning disabilities and was also undergoing gender dysphoria. And I would say kind of wax and wane with different depressive episodes, kind of with chronic dysthymia. So that's one kind of case. The next slide. Second case here is a completely different kind of patient. This is a 17-year-old with very poorly controlled diabetes. A1C through the roof, 14 to 16. I'm sure many of you seen kids and young adults with very poorly controlled like this. Multiple admissions for DKA since the initial diagnosis at age 13. Very, again, complex psychosocial family background. And that's true for a lot of the patients with chronic illness. Oftentimes there's a lot of family issues and some complex social issues. This patient in particular was very apathetic to the DK admissions, but denied very SI or specific depressive symptoms. So a very tricky and complex case. But again, maybe people have seen people along the spectrum of having kids with poorly controlled diabetes. So this is sort of a case kind of representing that population. And so next slide, we're going to just do the third case, which is, this is another patient of mine, a 10-year-old ex-preterm, I think it was a X26 weeker, with cerebral palsy, wheelchair bound, a victim of bullying, cognitive delays, and oppositional behavior towards caregivers. Again, having this very chronic disability influencing many aspects of this patient's life. And so again, I can go on and on with multiple other cases, but I just wanted to give a spectrum of different kinds of patients that I see in my clinic here, and I'm sure many of you have encountered. And you can think of cases similar to these patients. And so next slide. But I want to define a little bit more of the terminology that we're using when we say chronic illness. And so what's typically referred to is either someone who has a functional impairment because of their illness, so leads to, impairs their ability to attend school, engage in childhood activities. Prolonged is something that persists usually greater than 3 months in a year. I think it's and then the next period is necessitates a period of continuous hospitalizations for more than a month or requires frequent medical attention. This is the general sort of categorization of how you define a chronic illness. And if you use this definition, actually, possibly up to 1 in 4 children suffer with a chronic illness. And, you include in this category things like asthma, food allergies, things like that. But if you take in the more broad category, you're talking about 15 to 18 million children in the United States. And so obviously as pediatricians, many of us see these patients, through our clinics, especially if you use this kind of definition. Okay, next slide, please. But I also want to define what the different terminologies that are used. So many of you are familiar with PTSD, right? And the definition of that from the DSM-5 is the exposure to actual threatened death, serious illness, or sexual violence. And then there's 4 clusters of this: the intrusion, avoidance, negative alterations in cognition and mood, and hyperarousal symptoms, and has to last for at least 1 month in order to meet the definition. And I'm not going to spend too much time going into PTSD because that's its own separate topic. But there's another term called PTSS, post-traumatic stress syndrome, and that's like a subclinical PTSD. It's when you have symptoms of PTSD, but it doesn't really meet the full criteria, so they label that as PTSS. And I guess our kids may not actually have all PTSD, because one of the definitions of PTSD is that it has to be an exposure to an actual or threatened death or serious injury. And many of them do. So, for example, when I think about those cases I presented, certainly the kid with an optic glioma and going through all those surgery and the chemo, certainly the patient with diabetes, with DKA, but less so the patient with the cerebral palsy. Yes, wheelchair bound, and of course that can lead to potential situations, urgent situations. But throughout and there was the preterm issue. So maybe in that case, yes, but just in general, kids with CP don't necessarily have that exposure to actual threatened death. And so by definition, they can't really meet criteria for PTSD by the definition that we have. And so maybe they meet criteria for PTSS. But there's actually this third category here, which is coming up in the literature. It's not part of the DSM, but it stands for pediatric medical traumatic stress. And that's a set of psychological and physiological responses of children and their families to pain, injury, serious illness, medical procedures, and invasive or frightening treatment experiences. And so we see here that that there's almost this like other definition to define the kids. For example, our kid with CP would definitely fall under PMTS, medical traumatic stress, may not fall under PTSD. And also lots of kids will fall under PTSS. They don't meet all the criteria for PTSD. So, I just think it's good. It's helpful to just think about what terms we're using, because it does make a difference in terms of like the statistics that we look at, because only some kids will meet criteria for PTSD, but many more will meet criteria for PTSS. Next slide, please. But I also want to then get into some of the more differences, fundamental differences, not just like whether or not they're exposed to an actual potential serious injury or death, but there's some also big fundamental differences from what we classically think of PTSD and what I think is medical trauma, which I saw coined as an enduring somatic threat, which is a term that I really like. So I think it really captures a lot of the patients that we're seeing. And so, those four clusters, or some of the clusters I'm kind of using here to kind of show the differences. And so when you think about PTSD, you think about, let's say, a classic example of someone who experienced a past trauma. Maybe it was, you think of it, classic example of someone who was in war and they experienced some trauma in battle or a sexual trauma, right? Something in the past. And you contrast that with, let's say, a kid who's experiencing a current medical illness like diabetes or cerebral palsy, right? And so there are some very fundamental differences here. So you look at these, let's say, categories listed on this slide. So in PTSD, you're going to have a discrete event. You can do the next slide, by the way, which is going to be, and when you think about under the category, intrusions are going to be, let's say, past oriented, right? The thoughts are about the thing that occurred in the past. When you look at a chronic threat, something that's ongoing, the intrusions are actually future oriented, right? I mentioned like that kid, our patient who's constantly getting scans and labs every 3 months from now, right? So it's not something that happened in the past. I mean, also in the past, but really the intrusive thoughts are about the future event. In PTSD, generally avoidance is, causes hypo, you don't want to, let's say, go out in public because you may see a perpetrator or something. So that leads to avoidance issues, but potentially avoidance is possible. If an event happened in the state of New York, you can move to California and you're less likely to, encounter that same situation. But with, again, kids that we're seeing, let's say diabetes, avoidance is difficult or nearly impossible. You're constantly having to grapple and deal with it. Doesn't matter what state you're in or where in the world you are. And then the last category there is what's causing the arousal. So in PTSD, it's something that happened outside of yourself, right? Some person caused, a bullying episode, or, again, trauma like war or something happen outside. But in enduring somatic threat, it's something that's internal. It's like your own body, something about your body's failing you, like diabetes or something, a hormonal imbalance, or physical disability like CP. So it's also an internal distress. And so there are some just fundamental differences between what we classically view as PTSD and versus the medical trauma that we're seeing with our patients. Okay, next slide, please. And so what are the risk factors for the population that we're seeing? And what I thought was, reading through several articles in the literature about this is, number one, it's the perceived level of hazard. Now, they may be having lots of different difficulties and levels of threat, but it's all about how they're perceiving themselves within that context. And that is like one of the key risk factors in terms of whether or not they're going to be able to be resilient and get through this illness, or whether or not they're going to end up with much more psychosocial distress. Lack of control is another huge one. Of course, anyone with a history of any psychopathology or trauma, you think about their family's function and support. And of course, the nature of the actual illness itself is, of course, going to be an obvious risk factor, the severity of illness, the duration of treatment. These are some of the core things that we can think about when we're seeing our patients, who are the ones that are going to be more psychologically vulnerable to having this medical trauma. Okay, next slide, please. And as I said before, I think it's important to think about this through what we typically in psychiatry use the biopsychosocial lens. But I actually added two categories here. I think about spiritual, because I think that should be part of the biopsychosocial, I think in general, should have a spiritual lens. But I think there's also going to be another unique category, which I'm going to kind of label medical lens. Again, to our patients. And the next slide, I'm going to kind of list a bunch of the different categories that kind of come up, and they're going to be a little fluid, but it's not just a laundry list. I was actually very intentional about the different things that I listed on here. And if you go to the next slide, you'll see what I mean, because these are all things that I encounter with my patients to varying degrees. And I could actually probably give a talk on each one of these topics as it relates to the kids I'm seeing. And so I'm going to go through some of the different categories here, because I do think it's important to think about all these things when we're seeing our patients who present with a chronic illness. And again, the categories are a little fluid. You can probably put one in a different category, but this is sort of how I kind of distinguish them. So, biological, you think about their growth, you think about their body habitus, sometimes short stature, depending on obviously what the chronic illness is. Some patients present with dysmorphic features and physical limitations, cognitive impairments. Obviously, in the psychological, we're going to have the heightened traumatic stress response. You can think about this: kids who have to get frequent blood draws, lab, needles, procedures. There's a lot of what we see as developmental regression, attachment. I've actually given a talk on this topic as it relates to kids undergoing cancer treatment who, are now 3 or 4 and were sleeping independently in their own bed, and now suddenly they're sleeping again in their parents' bed. And so they definitely regress developmentally. Of course, we're going to have anxiety, depression. I'm going to get into another, my next slide. We're going to talk about demoralization with this population and kind of contrast that with depression. And there's a greater suicide risk as well. Socially, as I mentioned previously, there's often parent conflict. Maybe different styles of parenting, how to deal and cope with the chronic illness, different ways of viewing the chronic illness. Because often we see academic challenges, school avoidance. Sometimes they just have to miss school from their medical condition, and they get bullied. Abandonment, loneliness, bullying, and so they also want to avoid school. They're just different than the other classmates, and sometimes it's notably different. They look different. They're weaker physically sometimes, again, sometimes struggling academically, depending on what their illness is that may lead to cognitive impairment. But there's often school avoidance is a huge issue, as I'm sure many of you have encountered with your patients. And then we also, at some point, as they're getting into adolescence and young adulthood, we think about their transition to adulthood. And you think about, are they going to go to college? What does it look like getting married? I mean, these are things obviously all patients have to go through, but I think unique here is also going to be issues of like fertility. Did their, what medications are they taking? Is that going to impede their ability to have a child, get pregnant? Is it teratogenic? And also just, let's say they went through chemotherapy or something like that. Did that impact their fertility? Again, I have another topic here called medical, and I just put down here things that just are sort of comorbid medical complexities that we deal with. So frequent procedures, imaging, medications. And then, as I'm sure many of you've seen, lots of patients develop chronic pain. We've seen patients with opioid use disorders developing those patients who have chronic pain and are constantly given opioids to treat their chronic pain, and then we end up entering into that territory, unfortunately. Eating disorders is a big one. In fact, this is one of my areas of research, is looking at disordered eating within differently medically complex patients, and this is something I just gave a talk on at a conference several weeks ago. Again, we can give a talk on any one of these topics. I also think about spiritual, and when I say spiritual, questions that come up with those undergoing a medical illness that you may not see with other typical developing kids and young adults, right? Asking questions. Why did this happen to me? Parents asking, why does this happen to my child? And how do they view the hospital setting and the doctor's office? Is it a place of illness? Is it a place of healing? I also put ethical considerations. I think that comes up more frequently in this population. So things like, do you tell the kid, let's say a kid is, again, diagnosed with cancer, and how much information do you want to share with them if you're dealing with something like a terminal illness? Also, just in general, you have many kinds of questions that come up when kids want to be more autonomous with their, with their management, but aren't necessarily complying with, the treatment protocols and how to navigate that, and who's ultimately responsible. And you get into a lot of different gray areas with this. So again, I know this was a long slide to spend some time on, but I do think that this brings up some of the varying complexities that we see, and how to kind of think about it through different kinds of this biopsychosocial model. Okay, next slide, please. I do want to spend a moment also talking about major depressive disorder versus what we is termed demoralization. And so, next slide, please. And so, and this is a slide that's actually borrowed from one of my colleagues who gave a talk on this topic. And so, Dr. Mirren from Dana-Farber. And so, major depressive disorder, we think of, anhedonia, lack, low mood, lack of consummatory pleasure. Demoralization is what I think the best way to define it is that you have this hopelessness and helplessness, but is sort of in proportion to the stressor. Does it make sense that they're going through this? It's not necessarily, it's pathological, but not pathological the way depression is sort of out of proportion to what you would expect. Here you have something that actually is in proportion to the stressors. It's not, it's something that's not exactly due to the medical condition itself. It's not like their, thyroid hormone is depleted, and therefore they're experiencing, demoralization, depression. But taken to, there's a spectrum of this, and that first bullet point there, under hopelessness and helplessness, it leads to disheartenment, which leads to despondency, which leads to despair. Again, then you think, is this now entering into major depressive disorder, or is it sort of staying in this demoralization? But I think demoralization it just captures much more of the patients that we're seeing. It's almost like they're experiencing burnout from their illness. A recent review concluded that demoralization was actually present in up to 35% of those with medical illnesses. So next slide, please. So how do we assess for this? So obviously, having you have to have a chronic illness. There are some varying screening tools one can use to look and assess. Obviously, the patient interview is always going to be the best way to make assessments. But if you want some objective screening tools, these are just a list of different ones that are used. I actually found one that's interesting. The bullet point number 2, the heart rate at the time of diagnosis apparently can be predictive as to whether or not they're more vulnerable to psychosocial distress. But this is just a list of different measures that one can use to have more objective measurements. Next slide, please. So this slide looks complicated, but it's really not, and I think it's important because it just shows sort of the timeline of when do our patients start developing that psychosocial distress. And I don't know if you probably can't see my cursor here on the screen, but if you look all the way to the left, that's like sort of the starting point. The traumatic stress is sort of vertical, and as you see this this graph here, it's in the bottom sort of arrow is the time, right? So the starting point is they're given their diagnosis all the way in that, let's say that bottom left point there. And you see there's right away, there's sort of like 2 pathways, right? One that goes all the way up and one that kind of goes up to the middle and then kind of comes back down. And the one that goes up to the middle and comes back down, that we're kind of labeling the resilient group. Because as not everyone necessarily has medical trauma if they have a medical illness. Many patients with diabetes, are able to master their diabetes control and actually do really well and achieve great things. And we would probably label them in the more resilient class. And so they kind of get there really fast. But then you have the other population, which kind of goes all the way up to the top. And then that, again, then branches off into 3 categories. There's those that recover and become more resilient, like that first group. There's those that stay at that chronically elevated level. And then there's a group of individuals who actually escalate further and develop more psychiatric distress. And so the reason that I think this is a good way to conceptualize it is because the question is, when do you want to intervene? When's the appropriate time? And the answer is really right away. You want to try as much as you can to capture them before they even get to that top line. You want to see if you can create some level of resilience right away. You want to get them into care and support as quickly as possible. Now, if let's say you miss that window and they end up in that top line, of course, the next step is how can we help them become resilient? How can we help them recover instead of going into the other two pathways? Okay, next slide, please. So how do we get there? And the way I think conceptually about it is that there's going to be individual treatment. There's going to be, as child and adolescent psychiatrists and as pediatricians, I always think about our family networks and how can we think about the individual in the context of their family. And then, of course, what are the system issues that are here that we can utilize? And so next slide. And so, and these are just different models that I'm going to talk about. I'm talking about one in each one. Individual, I'm going to focus on what's called the health psychology model, which I think is really fascinating. I'll talk a little bit about medications, the family system illness models, how about that in the family, and then we'll talk about some of the system issues. I'll conclude with that. So next slide. So this thing called the health psychology model, which I think is fascinating. And this is borrowed from not have to do with medical trauma per se. It has some more general questions. And it asks questions like, why do people tan in the sun when it's bad for them? Right? Thinking about that, right? Think about ourselves. We go out and, well, maybe we do it possibly, but why do people, or maybe we were younger, why was it like such a burden to put sunscreen on? What was going on there? What's the psychology behind that? And one of the answers to that is that when we go out into, to the, outside and on a hot sunny day, or go to the beach. Um, by putting on sunscreen, we're actually in some ways recognizing our vulnerabilities, right? Because if we don't put on sunscreen, what could happen? Well, we can get burned, which is uncomfortable, but we have to worry about something like skin cancer. And so by almost not putting on sunscreen, or almost like not engaging in that thought, we're not going to think we think we're invincible. We're not going to get, we don't want to even think about skin cancer. But by putting on sunscreen, we're almost like acknowledging our own mortality and our own vulnerability. And so next slide, please. And so this psychology model breaks things down into what they call it the conscious level and the subconscious level. And when someone's given, let's say, bad news, they're diagnosed with, whatever, such and such illness. So on the conscious level, right, we have these intrusive thoughts, and there's this like human need to suppress the thoughts related to our mortality. So how do we do that? You think of a classic example, an adult, now we're talking about kids for a minute, adult, gets bad news and they go to the bar and they drink alcohol, right? That's just a way of distraction and avoidance, right? So they and of course we have kids who also engage in substance use, right? As a way to sort of almost distract themselves from dealing with these thoughts that they have to deal with in order to engage in the chronic illness. Like diabetes, you're constantly have to giving yourself insulin. The other one is also avoidance, so not taking your medications, which is, of course, another common problem that we see. Now, it's a dialectic, though. The other side of the coin is you can, in other ways, deal with this and grapple with it by also forestalling, our mortality by engaging in more health-related activities. And of course, that's the shift, and that's the paradigm that we want to do psychologically in order to help our patients kind of cope with those distressing thoughts. I also think it's interesting that what it does in this model breaks it down into what is called another subconscious level, which is just focus on values, self-esteem, legacy, is not kind of irrespective of health. Think of the things like bucket list items, things that we want to accomplish with our life, climbing a mountain, going skydiving, trip to Disney World, right? Depending on your age and what you want to accomplish in the world. And so next slide, please. And so on the conscious level, what we like to do is, again, kind of shift it to that second sort of part of that dialectic there. So for forestalling death, engaging in more health-related activities, it's accessing people's locus of control. This is all borrowed from the ACT form of therapy, acceptance and commitment. So you accept that this is the truth, and then you focus on what you do have control over, and engaging in more health-related activities as it becomes a locus of control. And that's how you deal with the conscious level thoughts. And on the subconscious level thoughts, you talk about your values, again, also borrowed from ACT. And what you want to do is you want to look at the values that are healthy and empowering, and focusing on those. So maybe, maybe climbing a mountain is okay. Maybe skydiving is not the greatest thing for your health. But maybe the trip to Disney is okay. So you want to focus on the values that are syntonic with your health. And so this is just like thinking through from a psychological perspective, using the ACT formulation to help our patients kind of cope with their illness. And this is sort of thinking through a little bit more of the psychology behind where they're going with their thoughts, whether at conscious level or subconscious level. I'm happy to answer more questions about this. I know it's not the most straightforward concept. Okay, let's continue to the next slide, please. I do want to talk about medication considerations. Oftentimes, we call them MCPAP. We're not sure what to do about these medications. I know, can you give us some advice? And the medication considerations in patients with chronic illness becomes a little bit more complex. There's some factors that we have to consider here that we don't necessarily need to always consider with our other patients. And so number one is always going to be polypharmacy. And I once gave a talk at ACAP, the Child Psychiatric Conference, and the title of my talk is, "Why is my patient on 18 different medications?" And that was a patient who was given a diagnosis of Ehlers-Danlos and POTS, for example. But of course, the polypharmacy there was really significant. So that's unfortunately what can happen with patients with chronic illnesses, of course, depending on the diagnosis and looking at all the different interactions. We always want to try to consider what are the non-psychiatric causes of symptoms. What can be optimized before we add an SSRI? What else could be contributing to, let's say, low mood or distress? Could it be their sleeping, their pain, nausea, constipation? I know everyone here kind of thinks about these things, but in particular with the chronic illnesses, a lot of them can impact those varying categories significantly. And so trying to optimize those areas before we think about psychiatric medications. Also, we have to be extra careful about the CYP interactions. So for example, medications like escitalopram and mirtazapine have more favorable CYP interactions, whereas something like Prozac has many more interactions than, let's say, the Lexapro. Also, it's very, very important. I do this all the time. I check with the study protocol. I call pharmacy. I obviously look at, up-to-date lexicon, but I also double check, double confirm before starting medications. I see patients with congenital heart conditions. I check with cardiology, before I, let's say, start a stimulant, just to make sure there's no contraindications and what the follow-up protocol and plan is going to be. Do we need to get an EKG? How often, etc. Things like QTC prolongation is much more profound in our patients. So, for example, patients might be on Zofran for nausea, they may be on methadone for pain, and then you want to start something like Lexapro. Well, they're already on 2 QTC prolonging medications, and so maybe Lexapro isn't the right option there, or if it is, we need to follow up with EKGs and make sure that we're obviously being safe about how we're prescribing it. The other thing that we have to always consider is, what about the effects on things like liver, platelets, electrolytes, lipids? So, an example would be, let's say a patient with diabetes needs a mood stabilizer, and let's say they need an antipsychotic. Well, mood stabilizer antipsychotics can increase their metabolic effects, increase their sugars. So, it has to be done in collaboration, of course, with the endocrinologist. You look at something like SSRIs and platelet function. So, thinking from the cancer population, patients oftentimes have thrombocytopenia, and SSRIs can impact platelet function, not platelet number, but platelet function. So if a patient has, 10,000 platelets and they're bruising, SSRIs may not be the right medication to prescribe because it can actually potentially lead to more bruising. So again, these are just sort of unique medication considerations that we have to consider with our patient population, with those who have chronic illness. And of course, every case is going to be different. Okay, next slide, please. I just want to spend a few moments, and we're going to have time for questions in just a bit, probably finish up in the next 10 minutes or so. I just want to spend a few moments thinking about the family system as well. I think the best summary of the slide is the quote at the top here. The goodness of fit between the psychosocial demands of the disorder and the strengths and the vulnerabilities of the family itself. And so this is a very complicated sort of model itself. So I'm kind of breaking it down into these sort of 3 categories here. You think about the type of illness, the time phases of the illness, and then you think about the values of the family. So next slide, please. So the type of illness, you think about, what's the onset, the course of the treatment, what's the outcome, how incapacitated they are, what's that level of uncertainty? Are they going to be getting scans every 3 months? Are we always going to be worried about this? Then you think about the time phase. So next slide, please. And then again, this itself is further broken down into several categories. But the crisis is what they call the initial part, creating the initial diagnosis, the initial onset, where you need to sort of create a meaning for the disorder, sense of mastery, grieving losses, coming to some of that acceptance. Then we have those who have, of course, have that chronic illness. You think about pacing, avoiding burnout, right? You think about those who demoralization, as I talked about before. And in this part, you think about the disease as sort of a shared challenge among different family members. of course, we unfortunately have patients who do have terminal conditions, and then you also have to think about things like separation and death and mourning, and of course, that's a whole separate topic. And then the last phase here, next slide, is the family system values. So you think about kind of number one and number two within the context of number three, the family system values. What's their culture? What's their religion? How do they respond to stressors in the past? What's their trust in the healthcare system? Think about the different life cycle of all the different family members, right? They have a kid, let's say, who's 12, who's diagnosed with a chronic illness. They also have another kid who's about to go to college. And what stress is that creating for the family? And what about the one who's going to college and they're not going to be there to support their sibling? Um, and I'll just kind of the last point here I think is really crucial. Um, and what we kind of see with a lot of our families, and especially again thinking from different contexts, and there's obviously chronic illness presents in different ways. But let's say someone with cancer, for example, and so they're constantly, the family is always focused on, okay, got to get until that next scan, got to get through this round of chemo, um, and they're constantly kind of focused on that, and instead of being just, I would say, like focus on that next stage, it's actually really important to focus on the present and focus on meaning making and focus on how we can embrace what we're going through now together as a family. And because that injects a certain sense of yeah, just meaning into the overall experience. And that's something I often advise families that, I know we got to get through this, but let's also take a moment and appreciate what we have now and what we're kind of working towards together as a family. Okay, next slide, please. So I'm going to conclude the talk by talking about some of the system issues, though. We went to talk about the individual, kind of thinking through from an ACT perspective in terms of like therapeutic perspective, talk about some of the medication considerations, just kind of talked a little bit about the family system and the family, the family ecosystem. And now we're talking about just general system. So a little shout out to MCPAP because of course, when we think about integrated behavioral care, MCPAP is a great paradigm for that in the sense that, we work together to, think collaboratively about how to help treat and manage patients. So, so in terms of how the integrated care system works, so MCPAP would be what we label referral part of our integrated care. There's also other models and other paradigms for this. There's another one called co-located. So I know some of your offices have sort of embedded, nurse, practitioners or even psychiatrists that are sort of embedded, maybe share office space, you do curbside consultations. But oftentimes, even in this co-located space, it's the pediatricians that are managing the psychiatric care of the patients. And then we have the collaborative model, which is sort of the last one at the bottom there. And that's where everything is sort of co-managed. There's a shared EMR, team-based, scheduled case discussions. And of course, there's models for that. Here at Dana-Farber, for example, I see patients I'm embedded in the psycho-oncology clinic. So I see patients together with the oncologist and we kind of co-manage their care. So next slide, please. And of course, the advantages for integrated care is that it promotes accessibility and family engagement. Actually, it also enhances provider wellness and prevents provider burnout. A lot of research on that as well. And there's also a financial benefit. I don't know, somewhere in the sense of it's a huge range, 26 and $48 billion in annual healthcare costs if we were to effectively use integrated care. It's a huge range of numbers. But the point is that it actually has financial savings. And so, just like MCPAP has been established and sort of an ongoing system, I think that the trend is moving towards more models of integrated care because I think also financially, it does make a difference. And so next slide. And so that's basically what I wanted to share with you guys. So I'm just going to kind of summarize our talks, and I'd love to also take questions from everyone. So we started off just kind of giving some general definitions of what do we even mean by medical trauma, right? We talked about what PTSD is, which is also could be relevant in our patients as well. But there is like this fundamental difference between the classic, what we would label PTSD, and what our patients with medical trauma experience, which we use, there's a term that I saw a client called the enduring somatic threat. It's something which is internal. It's something where we're constantly thinking not just about a past event, but something kind of ongoing in the future. And avoidance is almost nearly impossible. And so we have to, we think about all the different risk factors, our kids who are more likely to develop medical trauma are those with that perceived level of hazard, those with already pre-existing psychiatric vulnerabilities, and what their illness is, what their family unit is like. And so those are some of the risk factors. And we wanted to think about also how to assess this through a biopsychosocial, medical, spiritual framework. I know it's a lot. All the different kind of complications that our patients may experience, and and how to help them. We talked about different models. We talked about the individual model, right? We saw that graph about those ones that become resilient right away, those ones that kind of go up, and then you need to sort of help them become more resilient. And so, later on, we can try to help shift their path. And so there is, I think, probably the most salient individual therapeutic form is going to be borrowed from the ACT model, which is, acceptance and commitment. It's, there's two kind of parts to it: is accepting what the condition is, and focusing on what you do have control over, and also looking at values and finding those values that are syntonic with health, and can be empowering. Talked about some of the different medication issues that come up with our population, some of the more unique medication issues, things like QTc load prolongation, whether it impacts things like platelet function, thinking about the different labs you have to order and follow EKGs, etc. We spent a few moments talking about the family system, and of course, every patient we see is part of a broader family, and the vulnerabilities of the family or strengths of the family greatly impact our patients. And so, helping to create what's called like a shared burden, right? People in the family are already feeling the impact of the illness. And so it's much easier to do if it's shared over across all the family members. And also focusing the shift, not just from, okay, we got to get through this, but being more mindful and being more present, and getting, which injects a certain level of meaning into the situation. And lastly, the system issues, as providers, we thankfully have a MCPAP, which is greatly set up here in our state. And the different models of how integrated care works. But of course, as a member faculty of MCPAP, we are always here to help and assist you guys in the care management of your patients. And so I'm going to conclude with that, and I'm happy to take questions.
Thank you so much, Josh. It was a really beautiful talk. I appreciated it. I am looking at the chat, and I do not see any questions, but I have one. So why don't we start with mine, and then we'll see if others come in. I was wondering if you could say a little bit more about the slide that I don't think we need to pull the slides back up, but the slide that was focused on that issue about avoidance of preventive and self-care kind of behaviors, because we know how important self-care and just kind of managing kind of health risk behaviors is to the course of people's illnesses and their health. And I think your point was really good. I mean, the way in which avoidance of anxiety about death is a factor, and it is so natural. I think for one to I think we can all understand how if you're you don't want to be facing that fear of death, and sort of avoidance of self-care, kind of is in the service, of trying to avoid, coming to terms with that. And I guess, I think I would appreciate maybe a little bit more information about how you approach that, clinically, because you were talking about the ACT approach. I'm a fan. I love ACT, and I think it's something that I think many people in the audience, sort of need to be aware of that model. But I wonder if you could talk a little bit more about how you address that sort of, clinically, with a patient who you might be seeing who is, really, not complying with the guidelines that we're trying to teach them about how to take care of themselves and how to manage, their health. Yeah.
Yeah, those are some of the really, really challenging cases. And, I have to say that those are patients who I see where, they're really engaging in behaviors that are just really detrimental to their health. How do we re-engage them? How do we get them to sort of, collaborate with us to kind of shift their path into a more health conscious orientation? And so I'd say first and foremost, that takes time. It's not a 1, 2, 3, switch. That's something that will take several sessions. Obviously, developing good rapport is always going to be key for something like that. So you have a buy-in. I'm thinking also that like teenagers in particular need to have that buy-in. And I think about using an ACT formulation. I think I do and it's I have curiosity too. What are the things you find important? Let's list them out. And what are the I see some things coming in the chat. So you think about, like, yeah, what are the things that you find are important to you? You know, is drinking alcohol important to you? Okay, well, why is that important to you? I'm kind of always just curious why they engage. I want them to think a little bit about that. Um, and then the values that are important, then we kind of like grade them a little bit too. Okay, so being with your family is important. Okay, well, how much time are you spending with your family? Um, uh, you know, I sometimes use different sort of analogies. One that was taught to me that I really like is you're kind of you're kind of I mean, this is a little bit more of a CBT and ACT together kind of thing, but like you're sitting on a bus and you have all these different people on the bus with you, and some want to talk to you, and some are telling you to do things that are appropriate and fun and this, and some are telling you things that is not great for you. And so which ones do you want to spend your time with? Do you want to focus on, and can you tell the ones that are, can you tell the ones that you feel like are, maybe not the most healthily productive? Can they go to the back of the bus? Can we focus on the ones that are here? Can we tell that one to kind of, quiet down a little bit? Something like that. I mean, it's really, I think, I'd have to think about specific cases, I think, and then maybe share more how I dealt with a specific case. But
Yeah.
that's something that I think about.
Thanks, Josh, and I think it could be a whole, lecture or course, in of itself. We have a couple of questions in the chat. Actually, the first one I want to ask is from a person named Kathleen, who asked you to just speak a little bit more about how the spiritual conversation could go. How to address that component. And then if you could save time for another question, there's a person in the audience that wants to verbally ask a question. So, yeah.
Absolutely, yeah, and I know we have to stop at 1:15, so we only have a few minutes. So the spiritual. So I should also add, before medical school, actually was in rabbinical school. So I have some training, also in the sort of spiritual, in the spiritual world. And spiritual doesn't necessarily mean religious, of course. Spiritual can mean all sorts of things. So let me sort of phrase it like that. But I do ask people about their religion. I make a point to that. Are you religious people? What support do you have in that realm? Some people are, some people aren't. When I think about spiritual ways of coping, what I mean by that, and I really appreciate this question because I should have been more active in answering it. I think about things like gratitude, um, doing acts of kindness, for example, is a great spiritual way to cope with something, because what it does is takes the focus off the individual and puts it on someone else, and you also feel a sense of meaning when you go and help someone else with something. And so that's one of the spiritual sort of ways of kind of dealing with it. But I think your question is this question is more about, like, why did this happen to me? Um, and I will sit there with patients, and we'll ask the questions. I think the questions are better than the answers. But I think sometimes people don't ask those questions, and I think people are struggling with that. So I think just at least being, asking the questions, have you ever given thought to this? Or some people, especially the kids, think it's their fault. They did something to cause it. And I think that question at least opens up that conversation, and it can potentially relieve a lot of guilt that kids are experiencing as a result of that.
Okay.
I don't know if that answers the question or not, but
So I don't know if it's just my system, but you were breaking up a little bit at the end. But I'm going to go ahead and ask Lena, whose hand was raised, to ask her question now.
okay, sorry. I can always answer questions later. Sorry. Go ahead.
No worries. I heard it, the answer that you just gave. I just was thinking about also the FICA, FICA tool by Dr. I think Christina Puchalski, when I say her name correctly. She has some great videos and talking about meaning, helping people get through the dying process and other things like that. But my question was, I am a family physician working underserved population, and there's a lot of childhood obesity. And just an example, I saw a child yesterday was for sinusitis, but 240 pounds, BMI 44, 12 years old. And I'm seeing like prediabetes and severe obesity in under 10. I'm like, oh my goodness. But how to address that? And she has other comorbidities along with that, ADHD, major depression, all that stuff. But how do I approach obesity without creating further wounding? Which I'm sure she's getting bullied and all of that. Any ideas? It's a sensitive topic.
Really great question, and that's a really tough topic. And I also see kids through I'm referred to kids from our endocrinology clinic who have obesity and who are bullied greatly in school. And again, this is probably a longer conversation. I'm happy to chat offline at some point if you'd like. But I'd say that if what I've come to see is that kids are experiencing this stuff, and they need some way to express themselves, and some way of at least feeling heard and validated, and how far that itself can go in terms of making kids feel that they can turn to someone. It's at least the start of that conversation. I think all the time, and this is something when I was in medical school and even through residency and stuff, I was always like, I want to be a problem solver, and I want to figure out how to get this, how are we going to get your obesity lower, and how we're going to do all that. And over time, I've come to, I guess, at least more appreciate the process to it, and the conversation and the openness, and and being so non-judgmental about it, and being a place of safety, and for these kids, goes a really, really long way. And we'll get to the treatment too. I think that will come, and the referrals to whatever clinic and everything will come in time as well. I know that doesn't fully answer your question, but I think that's where I would at least start. And obviously, there's much more complicated stuff going on there, especially with how do you deal with medications? Do we want to do Vyvanse? Is that going to help with their binge eating if that's an issue? I mean, again, there's a whole path forward there as well to think about.
Thank you so much.
Yes, thank you. And thanks for the question too, Elena. And thanks everybody. Thank you, Dr. Brown. This was a fantastic talk, and I really appreciated it. And I think it was really helpful for everybody. And thanks to the audience for being here. And we will not see anybody until January in this particular space. So I would just wish everyone happy Thanksgiving and happy holidays, whatever holidays that you celebrate in this time of year, and wish everyone well, and hope to see you in January. So, and don't forget your pop-up survey.
Thank you, everybody.